other community agencies. Our presenter today is Dr. Eric Caine. At University of Rochester, New York, where he is also the chair of psychiatry and leads a number of efforts on suicide prevention. He was telling me that earlier today that he's also beginning some new work with the Veterans Administration, although I'm not sure how new it is, but some additional work with them, and is here in town for work with our state health department and the Colorado National Collaborative. Did I get that right?
You did.
And so we were pleased to be able to snag him for an hour to do this seminar. So welcome, Eric.
Thank you.
I look forward to your talk.
Well, it's good to be back, and thank you very much for having me here. Good to see some people I know as well as others I don't. Full disclosure, so I am trained as a psychiatrist. I did inpatient psychiatry work for almost a decade. The favorite places I had in working in psychiatry were either the inpatient floors or the emergency department. Shows you how strange I may be. And indeed, I worked with many people who were suicidal and really desperate and having difficult times in their lives. My interest in suicide began actually in university. I worked at a hospital in Ithaca, New York that was run by Cornell University, and I was the phlebotomist, otherwise known as a leech. You know, you take blood in the morning and that sort of thing. Also drove the ambulance and did a few other things. And in 1966 and 67, I was really impressed that 7 students had killed themselves, and I didn't understand why. Now, there were a number of things that is full disclosure, I had no empathy for that, in the sense that I couldn't put myself in their position and think, oh, I want to kill myself, and I've never been able to find that. And so part of me being me was I wanted to understand more what was going on with folks and really try to appreciate what they were going through and how they had come to the point where 4 of them jumped off into the ravines or gorges of Ithaca. Now, by the way, Cornell has no higher suicide rate than any other place, but it's very public when there are many suicides and people pay attention to it. And I continued to really have this focus into medical school and then sort of diverted into other things until the mid-1980s when I was mentoring a fellow named Yates Conwell, who is now one of the world's leading folks in suicide in later life, and asked him if he wanted to do psychological autopsies, and he said, what's that? You know, Yates has become an expert in psychological autopsy. But we went, and Rochester being small, went and worked with the medical examiner who I'd known, and we started doing work and trying to understand what was going on. And very clearly, being an inpatient psychiatrist, my view was all we had to do was get people into the mental health system and we could take care of the problem. And that suicide was an epiphenomenon of psychopathology. And needless to say, data, does damage to preconceived notions if you're willing to listen to your own data, and that turned out to be fundamentally wrong. And part of the reason I'm talking today about this is, I think that as a nation we have to rethink how we do suicide prevention. Now, Carol mentioned that I work as a senior consultant for the new Office for Suicide Prevention for the Department of Veterans Affairs and for the Veterans Health Administration. It's very clear that VA, as an example, has put in a huge amount of resources over the last 10 or 15 years into suicide prevention within the walls of what we might call VHA, and the suicide rate's not gone down. It's gone up a little bit. In the community, of course, veteran suicide rate has gone up very substantially. And across the nation, despite more spending on mental health, despite more psychotropic medications and the like, the suicide rate in the United States has just increased and increased and increased. And so if we're going to be open to our data, if we're going to be open to having reality hit us on the head once in a while, then we need to ask, well, are we thinking about this in the right way, and what ought we do different? So that's really what I'm going to talk about, and I'm going to go through some slides very quickly. And I want to say, I'm, as it were, thinking out loud with you, and I really want feedback because, I'm sort of reshaping how to present these thoughts, to consider them, to approach them. I've got to talk. It was very nice that I I'm going to receive some award at the American Foundation of Suicidology, or American Association of Suicidology at the end of April, and I'm going to give a talk which I think is basically going to challenge most of the people there, because people in AAS and other places have largely taken a mental health approach to suicide prevention, which is to say that the focus has been here to here. What's going on in someone's head at the time they die? How can we change what that person's thinking or doing so that she won't attempt suicide or he won't kill himself? And that has been the predominant culture in the United States for suicide prevention, such that people promulgate warning signs and symptoms. People talk about making acute interventions. We build all sorts of crisis services. And if those are really going to make a difference, they should have made a difference, and they haven't. Not at the broad population level. I certainly know as a clinician, I've made a difference in an individual's life when they lived long enough to get to the hospital. But we have to remember that most suicides occur outside the hospital. In the same way that in heart disease, when they built intensive care units in the United States in the 1960s, with all this Hill-Burton money, as it was called, that had been legislated in the 1950s, by the 1970s they found they hadn't changed the heart disease death rate at all, because 3 out of 4 people died before they ever got to hospital. And you had a much higher probability, if you lived that long, of living. So, in 2015, suicide's the 10th leading cause. And one of the things that I'm going to be doing, as you'll see, is I'm going to be making a transition in this discussion from suicide to self-injury. Because we've used suicide as psychiatrists, for example, or psychologists or mental health professionals, to think about killing oneself on the day that you die, killing oneself with intent. And I'm much more interested in people who kill themselves, whether they planned to do it explicitly or had a life of behavior and action that killed themselves, even though on the day they were dying, they didn't say, okay, this is my last day. So the suicide rate has creeped up such that it's now the #2 leading cause of death for a good chunk of the population, as we can see. And it really accounts for a large number of years of life lost and lost productivity. It hits in the middle of life. And it's very clear that it destroys not only the individual, but the families and the communities in which it occurs. And it's been creeping up. It's gone up almost 30% since 1999. And it's not easy to see in this slide. And all these slides are from Alex Crosby at CDC. But it's very clear that it's been going upward and going upward rather steadily, despite a substantial amount of attention in more recent years. Now, it's also important to remember that the suicide rate for men is far higher than the suicide rate for women. But in fact, the suicide rate for women in the middle years has been climbing in some ways at a faster percent than for men in the middle years. But the denominator is much smaller. Clearly, we see in later life that it goes up dramatically. And this slide and the next slide actually portend a major crisis in the United States, and certainly a major crisis for the VA. The baby boomer generation, here I am, a member of the baby boomer generation, and several of you are, has carried a higher suicide rate as a cohort through its life than any other generation before and after. And this generation is going to move into that period where, in particular, old white men kill themselves a lot. The VA already sees that 65% of its suicides are among people aged 50 and older. And that generation is going to be moving into later life. So, one of the things that I say to the VA is, if you don't start now, you're not going to be able to do something in 10 years, because putting your services and your programs at the edge of the cliff hasn't been shown to be effective in stopping people from jumping off that cliff. Now, we can already see that the bulk of suicide, separating rate from burden, the bulk of suicide is in the middle years, and you can see the baby boomers heading right towards later life. Now, it's very clear that there's also a tremendous amount of suicide in the middle years, and in large measure, some of that suicide may also be hidden, because we're having, at this time in the United States, a tremendous amount of growth in the intoxication-related drug deaths. And we know that medical examiners and coroners underestimate suicide in the context of drug intoxication deaths. When you have suicide with a firearm or suicide by hanging, it's rather unambiguous. Whenever it's ambiguous, it's always the default mode to call it accident. Now, we being several of us, don't call these self-injury deaths accidents. They're premature deaths. But when someone has a repetitive pattern of activity such that they're intoxicating themselves or may have multiple overdoses where they have to be resuscitated or get, how shall I say, narcotic antagonists as the kind of treatment that's now available, we know that this is a motivated behavior. It may be an addictive behavior, but it's also motivated by choice, as well as compulsion related to addictions and those sorts of things. And clearly the probability of death changes radically under those circumstances. Such on the day that someone died, they died by their own act, even if they weren't trying to kill themselves. So we think of self-injury mortality as one of the major kinds of premature mortality that we need to talk about. And Ian Rockett and I, Ian's at West Virginia University, and I had this as a commentary in JAMA Psychiatry a couple of years ago, well, a year and a half ago now, showing that, in fact, self-injury mortality, again, making some estimates about how much of the so-called accidental poisoning is actually not so accidental. It's different when a 25-year-old who's repeatedly using opiates dies versus a 2-year-old who gets them out of the cupboard and takes a poison or something of that sort in a household. But clearly, self-injury mortality has been climbing very rapidly, such that it's roughly the 8th leading cause of death, whereas suicide is the 10th leading cause of death when you take it alone. And so it's a very, very pertinent, present, timely consideration to say, what are we going to do about this? Now, one of the things that I'm going to make as a basic argument is that as a nation, and researchers, psychiatrists, public health thinkers, tend to classify people on what they looked like and what they were doing on the day they died, rather than what they looked like and what they were doing a year before, or 2 years before, or 3 years before. But we understand that prevention, if we're really going to look at changing things fundamentally, is not based on someone's characteristics on the day they died, but much more upstream. Now, one of the things that I'm going to show you is a series of slides, and I want to get your feedback on them. I may not make a convincing case, I'm going to try to, that there's a tremendous amount of overlap, geographical overlap and risk-related overlap in terms of different ways of premature death. So this is a map of suicide, the pattern of suicide death from 2004 to 2010. It may have changed a little, but probably not so much in terms of where suicide is heaviest in the United States in terms of rates and where it's less. You can see a pattern there. This is the pattern for firearm suicide, which looks largely the same as the one before. This is the pattern for poisoning suicide. Not identical, and clearly we know that we've had a tremendous, I think if the term epidemic is fair, of drug overdose deaths or drug intoxication related deaths in the Appalachians. West Virginia now is the highest in the country. How much of that's suicide? How much of that is opiate-related overdose? I don't know the answer to that. But again, there's a reminiscent pattern there that makes us think that there's a geospatial distribution that we have to pay attention to. Now, this is the homicide map, again from 2004 to 2010. And in some ways it's different. I mean, there's some overlap, but it's not the same. So you can look at California, which has much higher rates of homicide than it did suicide. We know that California actually has very high numbers of suicide because it's so large a state. But in terms of rates, it's very different. You can look, I can't reach up to Rochester, New York, but it's up there. And Rochester has a very low suicide rate, but it has a higher homicide rate, relatively speaking. And so, these are not synonymous with each other, but we think about them. This is the unintentional, as it's called by CDC, poisoning map for the United States. And again, there's some overlap. We see this Western, somewhat, the Appalachians, that kind of thing. This is the motor vehicle death map. Now, these are not all identical, mind you, but there's a fair amount of, how should I say, overlap, commonality, and it's important to ask the questions, how come? I don't have an answer for it, but it certainly starts to say to me, I ought to be looking at common features that are beneath, other than geography. Now, there's a public health rationale for suicide prevention, and it is really pretty simple. As many of us know, people who kill themselves often don't seek help beforehand. Seemingly normal people kill themselves. You do psychological autopsies and you find this out over and over and over again. You couldn't tell. He was the same as always. Yeah, he had some problems, but we never thought it amounted to this. Yes, she had some difficulties and, didn't look very good and was kind of pulling back, but she never spoke of suicide. The innermost thoughts are not always shared. An attempt at suicide where someone survives actually gives people an opportunity to intervene. But we understand, if you look at the data, that the suicide attempt rate is highest among adolescents and young adults when the suicide death rate is relatively lower. Suicide ideation is very common in high school students. Suicide as a cause of death among high school students under 18 and under is actually very low relative to other parts of the population. So there's no synchrony between ideation and attempt, and no synchrony between attempt and death. Now, as you move up the age ladder, that starts to change, but in strange ways. You go and look at elders, they often don't tell you about their suicide ideation, and they kill themselves when they die. Elder attempts are much more lethal than younger attempts. So we talk about younger people, their estimates anywhere between 20 to 1 to 200 to 1 of attempts to deaths. You talk about elders, and the estimates are 4 to 1 attempts to deaths. So they're very, very different phenomena. Fatal attempts are often the first attempt, and I'll show you some data later on. Men, by and large, when you look at the National Violent Death Reporting System, have their first attempt be the fatal attempt. Women in the middle years who die by suicide, more often than not, have had a prior attempt. So there are some sex differences. And of course, the risk factors are not really risk factors at the population level. And I'm going to talk about this because risk factor research and risk factor prevention efforts certainly have been the most prominent in the United States. Now, I confess to having contributed to this because we did psychological autopsies and said, look at the suicide group, they have depression, substance use, family turmoil, and all these other things, and they're so different from the community. Well, it's true they are different, but it turns out that none of those are predictive. And I will illustrate it. So, the United States suicide prevention efforts have been built on so-called high-risk approach. Now, this is an ecological fallacy because it's the population of people who die by suicide, if you concentrated that population, shares more risks versus the general population. But if you start to say, yeah, but I can pick that individual out of that population and make a prediction about that person, you can't do that. Now, in the general population, the suicide rate, depending whether you use age-adjusted or not age-adjusted rates, is about 13 per 100,000. If I took a population, which means in the coming year, right, 13 out of 100,000 people will die. So if I saw any one of you and said you're part of the general population, I could say with a 99.8 or 9% accuracy that you're not going to kill yourself in the coming year. Now, I know that people who've made a suicide attempt and have major depression have a rate that's about 50 times higher, greater than the general population, about 700 per 100,000, which means that if I saw one of those individuals in my emergency room, again, I could make a blanket probabilistic statement that you're not going to die by suicide. Now, I don't do that as a clinician because if I see someone who's deeply distressed and really thinking about suicide and has, gotten their firearms and other things, aside from the fact that it makes me scared, I also know this is a person who really needs treatment. So a population of people with major depression is certainly a group of people who need interventions and treatment. But that's different from being a suicide prevention program. Now, if I amped up this population pool so that the risk was 1,000 times higher, 13,000 per 100,000, I'd still be wrong 87% of the time if I said any one individual is likely to die by suicide. And that's what we've tried to do. The VA is doing that right now, where they've been able to amp up the risk pool by about 80 times, which means that the vast majority of people are not going to die by suicide. This is not going to turn down the rate of suicide in the VA, where there are about 1,500 to 100 to 2,000 veterans inside of VHA and about 7,000 or so outside, total veterans. So it's very important to understand we've poured a lot of money into gatekeeper training, into high-risk strategies, and it's not really clear that we've done anything. And we should be honest about that, because even though it challenges the way we think, and certainly as a clinician, I'm going to hospitalize or put into treatment people who've got all sorts of psychopathology or substance use, and with no hesitation. That's not the same thing as saying it's a suicide prevention program. Any more than saying that if I set up ICUs across the country in the 1960s, that it was going to change the heart disease death rate. Sure, it did, quote unquote, salvage some people. And now with clot busters and stents and all sorts of other things, we can salvage more people, but we don't have that for suicide once someone's dead or near dead. Now, I'm going to go through a series of slides. I don't know how well this is going to show. This is a fellow named Neilman who is out of Denmark, but really looked at data in the UK in particular. This is actually Danish data. And one of the really interesting things is that basically what he was trying to do is take risk groups or risk characteristics and then look at how people died prematurely. Now, something like DSH, deliberate self-harm, that's the European term, you can see that suicide, that's the dark bar, is much higher in terms of its standardized mortality ratio than something like accidental death. But when you consider that accidental death is much more common than suicide when you take all accidental deaths, and in the general population, it's important to understand that SMRs aren't really talking about the number, just the relative risk, or it's not quite the relative risk, but it's related to the comparative risk with the general population. But it's very clear you have something like drug misuse, and the suicide SMR and the accidental SMR are very similar. And what this is starting to say is that there are common risks for different outcomes. Now, obviously, you can drive this to the extreme and say deliberate self-harm contributes more risk to suicide relative to accidental death. But in the population at large, accidental death really contributes more burden. Now, let's take a specific etiology, traumatic brain injury. This is Sina Fazel. I don't say his name right, I know him, and he's out of the UK. This is actually a 41-year Swedish database on traumatic brain injury. And you can see that in the 6 months after diagnosis of TBI, what they did was compare the risks of suicide and other premature causes of death against the general population and with their siblings, because they used the siblings to try to control for environmental factors. And it's clear that there are some environmental or family factors. But with something like traumatic brain injury, external causes and all-cause mortality are raised in their risk, as is suicide. So whatever is going on there doesn't just contribute to suicide, it contributes to other forms of mortality. And this becomes a very, very important point, that if we're going to do prevention, it isn't just going to be prevention of suicide, it's prevention of premature death. That's really what we're talking about. Now, I want to show this slide. This is out of the UK. And Helen Bergen and Keith Houghton, and I've known Keith for 30 years. And this was a group of men, and I'll show you women in a minute, who had first shown up as part of a UK national study. They followed 30,000 people. They showed up with a index suicide attempt, deliberate self-harm. Let me be clear, that's what they called it. And they talk about premature mortality. Now, what you can see is that there were premature mortality, this is the men, on the order of, I don't know, 15 years, 10 to 15 years from natural disease causes. And it turns out that these relate to the risk factors in these men. Drinking, substance use, poor nutrition, poor lifestyle. External causes, meaning suicide and accidents, contributed to about 20% of the mortality. The self-harm population died prematurely over a number of things. And I took away the disease markers because I was trying to do this. And so here are the years that it was talking about. This is the women. I should have made the slide a little more astutely, but you can see the women here also had premature mortality, both to medical and to external causes, natural causes and external causes. There was much more overall mortality, ultimately, from natural causes. But this was, as I said, a group defined by a suicide attempt or deliberate self-harm. And these are total years of life lost among men and women who have self-harmed. So the men are the dark, the women are the lighter ones. Accidents, intentional self-harm, you could certainly see those. Circulatory disease, digestive system disease, undetermined, and so on. But remember, far more people died from these causes cumulatively from their non-suicidal injuries, even though they're very high. When you accumulate all of them, it's their systemic medical diseases. So a population that's defined by a suicide attempt has premature mortality from other causes. Now you can also, this is actually another paper they did which simply shows for the hazards of suicide and accidental death that all accidents, if you take them, climb substantially. And again, the number of all accidents is going to be higher eventually in a broad population. Now, this is the National Violent Death Reporting System data from Deb Stone and Kristen Holland and several others at CDC. And what I'm really putting this up to show you is the kinds of problems that were going on in people's lives before they killed themselves. Family violence, intimate partner problems, legal problems, financial problems, and a whole array of different kinds of issues. Now you can see mental health problems were common. Service delivery was not common, generally speaking. Less than half of the women, and certainly an even much smaller proportion of the men, had received mental health services. Oh.
You just touched
Try
her.
touching something.
Maybe it doesn't.
Take my word for it. Okay, I'll keep talking. So one of the things that's really clear is that when we look at these populations, they're fraught with difficulties that we see in any general population. Sarah's working hard to get IT here. And so it's very clear that if we start to put in place suicide prevention programs, and I'll show you some data from the Air Force in a few minutes, maybe, that when they put in their program, which lasted from 1996 to about 2007, and then faded away for lots of, we'll call it institutional reasons, what they found is not only did suicide go down, but accidental deaths went down. Now, accidental deaths were often related to drinking in the services. Less to substance use because they threw anybody out who had dirty urines. But if they had drinking, if they had family violence problems, these were intervened with. So what they saw was a rise, in fact, in mild family violence. or family disputes, but a dramatic drop in moderate and severe ones because they set up a prevention program trying to screen these much more early, and they not only saw a drop in suicide and accidents, but also in homicides. So what's clear is that you start to build programs that get at what I would call common risks, and you start to have impacts across multiple domains. I'm back on? Okay, cool. And we can think of it this way. If you think about this sort of accidents, homicides, suicides is the kind of the top of your mountain. You've got mountains around here. So, yes, it's back on. Did you do something?
Someone's coming to look at it, but it just magically started working.
Whatever.
Okay.
Carol was giving it a dirty look and it went back on. She intimidated it. So in any case, if you start with disruptive family factors and disadvantaged social and economic circumstances, it's often that you're going to have major impacts on people's lives. But as a psychiatrist, do we pay attention to that? No, we see people in hospitals. Now, another way to look at this is something called equifinality and multifinality. But we look at all these risk factors and say, oh, we're just interested in the suicide. So that's about 44,000 people in 2015. On the other hand, if you looked at all the risk factors and said, what do they actually lead to? Suicide, drug overdose, medically related deaths, there are hundreds and hundreds of thousands of people. So if you were going to spend your money, would you focus on the people near the 44 or the ones who come into the emergency room? Well, obviously you have to deal with them. I'm not saying turn them away, but it's far more cost-effective potentially to focus on the risks and then try to measure the outcomes. This was the Air Force data. I mentioned that. So I'm going to skip ahead looking at the time as well. Now, suicide prevention is in theory possible. And I'll give you a couple of examples. The top one, Finland, it's the dark boxes. This is WHO data. You can see that Finland's come from about, it was actually up as high as almost 30 per 100,000, down to about 15. Still very high, but nonetheless a dramatic drop. And this blue or purplish blue, whatever, violet, is Denmark. And they brought their numbers down, again, dramatically, from about 1,600 deaths a year to about 600. And now there's some interesting things about these countries. They took what you might call a full court press. Everything went into it in terms of substance use policies, driving, access to health care, access to mental health services, following up people, and doing all sorts of things. Now, they're also smaller countries, 5 to 6 million people, relatively homogeneous. And one of the things that it teaches me two things. One is you can't do something as large as the United States all at once. You have to put this into chewable bites, as it were. The other thing actually was in a bar in Finland at the last year's injury meetings. So I was in a bar with a bunch of people from injury control centers and some CDC people, and I decided I wanted to have a drink because they had all ordered wine and drinks, and I said, I think I'll have an Irish whiskey. And I said, okay, I'll have a double. She said, no, we don't serve doubles. I said, you don't serve doubles? Well, you can come back for a second one, but we don't serve doubles. It turned out that none of the bars in Finland serve doubles. And I'm very clear that they would count how many times you went back to drink. And if you really wanted to get drunk, you'd have to go around to a bunch of bars because they are so restrictive on their alcohol use. So they're trying to prevent road injury accidents, but they also know that this contributes to suicide. And they were doing psych autopsies about the same time we were, except they pulled the whole country together in 91 and 92, took the data from 1,200 psychological autopsies and said, how are we going to change our society to deal with this? How are we going to look at this systemically, not just in pieces? Mindful of time, I'm going to skip a couple of things and really try to draw us to some fundamental issues. We do, selective and indicated public health interventions for groups or individuals who are symptomatic have a lot in common with clinical interventions. They are trying to get people who don't have full-blown disease yet. But they reach into communities. They don't wait for people to come to clinics. They don't wait for people to come to the door. If we think about an indicated intervention, say someone comes into an STD clinic, right? We don't wait around for all that person's partners or contacts to come back for treatment, and when they've got disease, we go out and we find them. In public health, that's sort of taken for granted. It's not done with suicide or attempted suicide or people who are at risk or people who are on the trajectory. We view suicide still as a private matter, even though we call it public health. Feel free to kill yourself because we're not going to intervene. Now, that sounds rather harsh of me to say, but in fact, that's really our attitude of a lot of people. My mental health, my personal well-being, my family violence, my whatever is my business. And that's a real cultural question that we have to really talk about together and don't have an answer to. I don't have it. And a universal prevention obviously is trying to shift the population. And really what I'm going to be arguing is we have to do a lot of that. Because if we understand the risk factor work, it really is needle in the haystack that we're trying to pull out, or needles, and we're not going to do that effectively. So obviously one of the big issues is around firearms. And we have to find a way of having a discussion around means and methods. This is a very, very complex issue in the United States. It's not something that anybody can dictate given our laws and our culture, but it's very clear that in many parts of the world, removal of pesticides, for example, has turned out to be very powerful in China, in Sri Lanka, in parts of India, in other countries where they swapped out one kind of pesticide for another in order to have people exposed less to the more lethal forms of the pesticide. Now, there are ecological factors and social factors. You can't take away the buildings in Hong Kong where 50% of the people die by jumping off of tall buildings, most often from their own apartment or their own, sort of apartment complex, if not the room itself, then next door or in what's called the estates. That's apartment complexes. And obviously, social forces in the United States lead to firearm concerns and intruding on people's autonomy and independence for that. So part of what we have to do, if we think about a universal approach, is to create a culture of safety and caring where people appreciate that there's something in it for them to create safety measures. And I don't talk about the terms firearm restriction or restraint, but rather, how do you create something that's built around protecting your family and protecting yourself and protecting your friends? This is going to be, I think, a major discussion coming forward in the country if we ever are going to talk about suicide prevention. Now, another method that we have to think about is actually we have to think about how communities are constructed and where we would encounter people if we were going to try to begin to build broad approaches to prevention or approaches to people who are on a trajectory towards death but aren't, at the emergency room door yet. And so every part of a community has what you might call populations that are potentially engageable and places where you'll miss parts of the population. They all have sample biases. And I'm going to go through this rather quickly, but you can see basically there are all sorts of settings that we can pick. And you can talk about organized work sites, and you have employers and EAP programs, and you could do screening there. But who's going to, look at the union halls, or who's going to look for the undocumented workers, or who's going to look for the day workers, or the people who are self-employed and have small businesses? These are the kinds of things that we have to think through as we develop programs, and that's just an illustration. Among youth, we have all these school-based programs, but the kids with the biggest problems are the ones who dropped out of school and are not in the school-based programs. In fact, going to universities is protective against suicide, even though we have a lot of attention in universities to suicide prevention programs. It's the kids who don't go to university who are, in fact, far more vulnerable than the ones who do, by self-selection, by resources, by family support, by community. So you can go through every community and you could make up a list of all communities, and you could also talk about social media as other kinds of different kinds of community where you can think about both populations that you would engage and populations that you miss and have to think about. Now, if you are interested in groups which are higher risk, and I think we should be because we know they need treatment, there's no question about that, and there will be a higher concentration of death among them, even if we don't know which individuals will be those who die, then we can actually say they have a social ecology. We can track them through communities and try to understand where they are and how we would engage them before they came to the edge of the cliff or the edge of the ledge. And that's why I put this kind of thing up, because it's very clear that it's important to find these groups that bear greater risk and appreciate that a group-level interaction for a high-risk group is not the same thing as trying to pick that one individual or 2 or 10 out of the group and giving them special intervention. And so there's a fundamental difference in philosophy in that sort of approach. And again, you can track all of these kinds of groups that we think are important and say, where would I engage them? So we have to start bringing this together and thinking about it in a coherent fashion. So I use the term that suicide prevention is a mosaic. It's, no one piece makes the picture. You put all the pieces together and you can start to see it. And I've tried over the years to think through how to do this, and I've struggled with this, and I'll show you several different attempts. Now, there's the social ecological model where you talk about relationships. This has certainly been used in a lot of different settings. I've amplified it many times over, so I've gotten more and more risks in this kind of model with the overlap of violence and suicide and things of that sort. It plays off of the systems approach, and it doesn't actually give you any guidance, though, on what to do, where to place your bets, where are you going to put your pennies, dollars, $1,000, $1 million, if you were going to set up a program. It doesn't give you any sense of that per se. You can actually make up a list of all the interventions you would do, which I did as an exercise. All the interventions I would do relative to risks or the protective factors that I might have. But again, it doesn't really give me guidance on how to set up programs that actually exist in real communities or in real societies. Now, another kind of piece, this is Tom Frieden, who I guess is no longer head of CDC, but was for a number of years. And he used this kind of pyramid. I was very happy to see this come out because I'd already drawn my pyramid with the different mountaintops. So I thought, pyramids are in. Not that it helped any funding, but nonetheless. So socioeconomic factors at the base. Counseling, education, and clinical interventions have the least impact at population levels. And it's always difficult for those of us who are clinicians to swallow that, but I learned. So a different model. Now, I didn't call this the Colorado National Collaborative because I actually made it up before we had the Colorado National Collaborative. But this is kind of what we're moving towards. Now, the coordinating center, I could say Jared Hyman right in the middle there. With Jared's name, There he is, Jared, like kind of Atlas, But the idea of pulling together some operation that's coherent and cohesive that has not only institutional authority, but moral authority. And moral authority is very, very important in this kind of activity. And then brings together all of those organizations that we talked about. Now, I talked about organizations for different age groups and different populations. And it's very clear that the suicide prevention program that would be useful for a 72-year-old is not going to be useful for a 22-year-old. But at times we've just sort of blanketedly deployed things and say, we got to go out and do this. Gatekeeper training, warning signs, and those sorts of things. But they're not deployed in a way that actually reflects either the geography or the ecology that we think about when we think about different populations. So this is our attempt at getting at some of this. And it's pretty crude, but I don't know how else to do it so far. So you can think about messaging. global, population-oriented, all sorts of kinds of messaging that you use to create culture, and using social media, and working through all sorts of state agencies and communities and community agencies and NGOs, supported by data systems, data. Because if we don't measure, we don't know. If we don't measure, we won't have continuous quality improvement. And by and large, suicide prevention in the United States has been devoid of real-time measurement that gives feedback to people about what they've done. Now you can think about different places, and for instance, courts and criminal justice for youth, actually the numbers are very small there, but the rates among those youth are relatively high. Schools, very big in terms of the denominator, although the rates are low. And actually the numbers are pretty low. The healthcare systems, a lot of kids pass through the healthcare systems, but not, where do you go when you're a teenager? You go because you got the flu, or you've got a strep throat, or you got a health physical, or something like that. Or, you're going off to college and you got to get something signed by the doctor. I'm left-handed, so something signed by the doctor. But those are not the kinds of screening opportunities necessarily. And how many of you have or have had teenage children? How are you today? Fine. What was your day like? Normal. Hey, let's talk about it. Oh, I've already talked to you enough, Dad. I want to go off and do my thing. Now, what happened last night? It was all right. You get home all right? Yeah. Any problems? No. That's a various sampling of my children a number of years ago. Fortunately, they're more verbal now. But health systems actually don't have much leverage for us in mental health is even less so in some ways. Yes, there are a lot of kids who need mental health services. Yes, there are a lot of kids who need substance use services. When we get those kids, obviously, we have to think about suicide. But the bulk of kids don't go through those. And the bulk of kids who die by suicide, if you look at their histories, haven't gone through those. Now, the picture is different for adults. Again, culture of safety and caring and messaging and social media in the same frame. But we've got work sites, and we don't know really how to engage millions of people in work sites. We don't know how to work our way through, hey, they've been trying the military for years now, right? That's a big workforce which has gotten hundreds of millions of dollars, and we still haven't figured out how to do that well. You take something like the Postal Service with what, 700,000 workers, or some of the big industries with 1 million workers or something of that sort, or Walmart or something. How would we actually make a partnership with an organization like that? We've never walked up to that yet. Sure, the mental health system and the substance use treatment systems are larger, but so far we don't, again, know how to get out beyond our walls. But that's the areas that we have to work. The courts and the criminal justice system are very enriched, that's in quotes, in populations that are at very high risk. We know that men who kill themselves in the middle years often have been perpetrators of intimate partner violence. And they flow through the court system, not that they get screened, and they often flow through the court system long before they become suicidal. Now, the victims are often suicidal, but actually women victims don't kill themselves very much. Men perpetrators kill themselves much more. That isn't to say that women victims don't suffer not only suicidal thinking, but PTSD, depression, and a whole variety of other problems. So the courts and criminal justice system give us one area where we can focus. VA and health systems, potentially another, but again, this kind of health system is going to be less useful for a 35 or 40-year-old man than it would be for a 35 or 40-year-old woman. But here's the interesting thing. If you remember that data from NVDRS, 60% or more of the women had previously attempted suicide before they died by suicide. That tells us there's an opportunity there for women in the middle years that we're obviously not taking very well. So there are indications that the health systems could be very important. This is where something like the Zero Suicide effort really stands out as having a potential. if you start to look at the population data. About 35% of the men had attempted before. So for them, again, their denominator is much bigger. So that 35% is actually a significant number of people. So what are we doing? And that's where, I am a supporter of the notions of zero suicide, maybe not the terminology, but the intent of building a much tighter framework in health systems. Now, if you take elders, on the other hand, healthcare systems have become really the place to go. Because we know, in the context of Medicare, in the context of aging and chronic disease, that suicide, people who kill themselves, flow through their primary care offices in the last month of life. Studies as high as 70% in the last month of life. We saw like 40% in the last week of life. Now, the challenge is I reviewed a whole bunch of those primary care charts, and you get it's almost like a conversation with the teenagers. How are you? Fine. Old white men are not a font of emotional expression. Everyone in this room accepted, of course. But this is also, we see this in the VA and the military. People who strive to be resilient and self-sufficient don't necessarily like people intruding on their mental life. And they think they should take care of it themselves. And so I reviewed these records, and it was really remarkable that, I knew a number of these primary care docs, and very good docs. And they would clearly had talked to the patients about what was going on, and patients basically denied these things. Now, I'm not using denial in the sense of a psychological thing. They just didn't tell. Because with elders, suicide is far more often planful, organized, covert, and calculated. So we have to think about how to use these healthcare systems in different ways. And I think there are ways to do it, but it's around pain, social isolation, less interactions with others, loss of joy in life, loss of interest in things. But if you ask, are you depressed? A lot of people will say, no, I'm not depressed. But they will say, I'm not as interested, I'm not as outgoing, I'm not as active, I hurt too much, I can't get up in the morning, it's painful. And so there are a number of targets for treatment and interventions. And again, changing the trajectory. So I'm going to finish up quickly because time's a-wasting. And whenever you put together a program or effort, you're going to ask, what are the goals? What are the objectives? How do I do it? How do all the pieces fit together? Who do I expect to reach and who will I miss? What am I going to change? And then I'm going to say over and over and over again, how am I going to measure it? How am I going to measure it? Confident in our findings. Are they exportable? Is it just because we're ardent advocates? The Air Force has never been exportable. They had a program that they couldn't even keep going because the leadership changed, the priorities changed, and they couldn't sustain it. They're trying to rebuild it now. But it's very clear that this requires ongoing attention and focus if it's going to be successful. And if we can do good things in Colorado, it's great, but it's not just how can we do good things this month or this year or next year, it's how can we do good things all along. Because it will fade. And, basically this is measure, 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 measure. Data, evaluation, don't take things at face validity, but actually see whether they make a difference. And one of the important things, and sort of the last point is, if we're going to do the kind of multi-level, build a mosaic with all sorts of parts, we have some real challenges in actually how to measure outcomes. Because we're going to be looking not just at who died, but things long before and asking, do we make a difference in people's lives earlier? So did we make a difference in intimate partner violence? Did we make a difference in how people are adjudicated or sent to care? Did we make a difference in substance use in the community? Did we make a difference in whether people stored their weapons in a careful way? How do we measure that? That's going to be something that's a real challenge. But it's those intermediate outcomes that will tell us whether we're on the right path. So thank you. I've tried to fit within the time. I guess I went 2 minutes over. But in the context of our technical delays, I shoved it in and certainly will be around for conferences.
Thank you. I think we can stay say until somebody kicks us out of the room. So if there are questions or comments.
I do have a question. The information you showed regarding Finland, I thought part of their, and I could be wrong, but I thought they also implemented daycare for all families, a lot of early intervention, reading ready for school, so kids were more successful in school.
Well, the Finns have a very interesting philosophy. I was riding on a train back. This is an illustration. Injury meetings. Someone helped me get on the right train as opposed to the wrong train, and she was working. Her PhD dissertation was on bomb shelters in Finland. And I said, bomb shelters in Finland? And they still build bomb shelters because they have a next-door neighbor that they worry about. But the goal is to be able to house approximately 80% of the entire population in bomb shelters. And I said, that's really interesting. She said, well, yeah, we always take care of everybody. That's our philosophy. So the collective approach that you're talking about is something that spans the life course. And the question is a diverse country like ours, how on a much more local level can we build this collectivism in a culture which is very individually oriented? And that, I think, is going to be part of our challenge. How do we create a culture of caring and a culture of safety such that we have some of those impacts? Now, you're talking about a specific thing, child rearing. But I'm meaning it more broadly. We have had in our history at times a sense of community or communities. And obviously, we're in a real struggle now, and there's you might call a major national set of discussions going on about community and communities. But I don't think that this is actually conservative or liberal. I think this is basically how do you view the value of people around you. And I think this is going to be one of the questions that we're going to be struggling with over the next couple of days as we do our planning together, which is how do we think about building a common sensibility that we're in this together. Now, one of the things that I say in the VA, and I think we had these leadership discussions, and also to other federal agencies, is, for example, that if we don't reduce suicide among veterans in the United States, we'll never reduce the suicide rate in the United States, because they account for 18% or so. On the other hand, if we don't reduce suicide in the United States, we'll never reduce suicide among veterans. This is really a community issue. It is a classical thing where we're talking about things that reach beyond ourselves but affect each of us. And so you're right. The Finns say, hey, on the rare occasion that there might be bombing, we have to bomb shelters for 80% of the country. They're still building them. That's a collectivist society. Now, I'm not saying I want to be Finland. It's kind of gray. It actually reminded me of Rochester, where I just came from, where it was 19 degrees and overcast. But
no reindeer.
No reindeer. No reindeer. But we got lots of deer in upstate New York, more than we want. But that's really, I think, a major challenge, and it's not the kind of challenge that we've had a good discussion about around things that are very important. And one of the reasons that I'm eager to be very supportive of veterans in particular is I think veteran prevention may be a way to rouse community. And of course, two-thirds of the veteran suicides in the United States are not people who are cared for by Veterans Health Administration. That's, the people who are so-called enrolled. 14 out of the 20, they say 20 every day, 14 out of the 20, almost two-thirds, are veterans in communities. So can we rouse people's interest to reach out and build community for a population of people that we value very highly? But if we're going to do this for veterans or adults and elders, if we're going to do this for that population, we're not going to do it in isolation for other adults and elders. We're going to say, how do we create a culture of help and collectivism and support, even though we're very much individuals who have our own autonomy and all those other things. So I think there's a national discussion to be had, and we'll see how it goes.
So if one really, I think that's a really good question, and if one is really going to take a population perspective and not look for high-risk groups, I mean, what can we learn if we ask the question, going back to that same slide, of what's different about Korea and Denmark?
Okay, well,
or Korea and
well, let's talk
Finland.
about. We can talk about Korea because it's stunning. But I didn't say we wouldn't look for high-risk groups. I said we wouldn't build ourselves on.
Well, but I think some of your argument is focused on high-risk groups.
Yeah, of course
and
it is.
I would argue about that.
Well, but they come to hospital, they come to services. Of course, we're going to offer services to people who come. So what happened in Korea? And I don't have a 100% answer, although we published a paper. I work with people, a very good epidemiology group in Hong Kong, at the University of Hong Kong, Paul Yip and colleagues, and I've known Paul since 1999. Tease each other, argue with each other, prod each other. And we were working on how the suicide rate went up and down during the economic crisis there, and I started to get to know his graduate students. And so we started looking at other examples, and we started to look at Korea, and there was economic dislocation with the recession in 2008. We started looking at that, and I said to one of the students, Jeff Chan, I said, Jeff, I think you should go back and look, not just at 2008, let's go back and look back 20 years, over which time the Korean suicide rate's been going up like that. And let's look at migration. And let's try to understand urbanization and migration in Korea. So what you've had in Korea, which is now happening in China, is this tremendous internal migration from, with industrialization and urbanization, and basically the fracturing in Korea of the traditional family structure. It was a multi-generational family structure that would live together, grandparents, parents, grandchildren, sometimes great-grandparents, much in rural areas, not in urban areas. And as the industrialization occurred and the academic specialization and the highly, ambitious growth of the country, you've also seen the, reduction of what had been multi-generational families to nuclear families. And suicide rate among elders skyrocketed. Suicide rate eventually among younger people started going up. And it's very clear that the society has undergone has one mindset, which is a very traditional mindset, but has a structure that, or functional quality that looks much more like the United States in terms of independent nuclear families. Now, in the United States, that's much more, we're an immigrant society. We, despite some people forgetting that right now, we are societies where we're highly mobile with the expansion of the country, with, sort of the 1950s, 60s automotive migrations and all the other kinds of things that have really built into our culture, not only individualism, but, the idea that, your family could be in one part of the country and another part of the country another. And it's a different mindset. And I think in Korea, there's yet to be the kind of recalibration. And you talk to people a lot, and there are those kinds of things, along with the stress about academics and achievement and all the other things that are there. And so I think China, for example, which has seen a reduction in its suicide rate with the change in pesticide, is likely to see an increase in its suicide rate in the future, with around some of the very same things, and are already starting to see signs that in rural areas among elders it's going up. In China, suicide's quite high in late life already, and it may be going up still more, because what you have in rural China is the whole phenomenon of what's called left behind. And this was seen in Japan in the 1950s and 60s, where you had the same kind of fissioning and breaking up and fractionation of the social structure and the rise in suicide, particularly in rural areas and with elders. And there's some work to try to counteract that. And I think we've seen it in Korea now, and I think we'll see it in China in the future. And you don't have that in some of those other countries.
So maybe the answer is building different kinds of community structures.
Yes, I absolutely agree. But I don't think there's one simple answer. I think it's a multiplicity of answers, because building community structures, which I see as very important, it's going to take time. We're still going to, it's kind of like, of course I have someone at my emergency department door or someone in the community that I'm worried about now. That person needs clinical care. And We can go look for some of these populations that are displaced and disenfranchised, where we would say collectively they have higher risk. Not that I'm going to pick out the individual, but I'm going to build selective interventions around those populations, while at the same time understanding that we have to build community efforts which are radically different from what we've done. If I said to you, suicide's a public health problem, and I said, well, and I'm going to give a radical example, and don't hear me saying I support it, but I want to. So in Taiwan, they said in the 2000s, suicide's a public health problem. It's a terrible problem. It's going on. And they started a national registry, not only of deaths, which they have like our national death index, but of attempts. It was supposed to be that everybody who showed up in an emergency department was registered in the national registry all over Taiwan for having an attempt. Then they said, you know, we're going to ask them if they'll consent to having local people reach out to them, even though the national registry's in Taipei, or provincial registry, depending on whether you're Taiwanese or from mainland China. I'll be politically neutral here. Then it turned out that about a third of the people gave consent. The local authorities ended up contacting almost 90% of them, far more than ever gave consent, and said, how are you doing? Can we offer case management services? What else? So they, in fact, intruded on people in a very open sort of way. Turns out that it looks like the group they were able to contact once they contacted him, had a 22% lower suicide rate than those who they didn't contact. So it raises an interesting ethical question. If we had a registry, an attempt registry in Colorado or New York or the United States, you know, different attempt registries, and we said it's for the purpose not only of cataloging your case, but making sure that we reach out and touch you and offer services to you, most people would view that as unwarranted and intrusive. Even if you were in your own health system where, you know, you had been in the emergency room and they have your medical records, so it's not a HIPAA violation. They still might view it as intrusive. On the other hand, it might save some lives. How do you make the balance? I don't know the answer to that. But that's the kind of discussion that we have to consider, because that's what actually zero suicide talks about, you know, making all these contacts, doing all these follow-ups, being a pain in the butt once someone shows up in your emergency room or your inpatient service, nagging them towards health. Is that okay in the United States to nag somebody towards health from the health system side? To make sure all the connections are made, no dropped handoffs here. Well, this is an interesting issue and one that we'll be talking about, I'm sure.
And the classic dilemma of public health.
Yes.
Immunization to
yes, exactly.
everything else.
Mandatory psychiatry.
I think we probably should
Oh, heavens
stop
no.
there.
Heavens no. I don't want mandatory psychiatry.
I think we probably should stop.
Does that go
let
for the
people
psychiatrist
go.
too? Never mind.
But thank you again for being here, and thank all of you for participating.